Hi, I'm Dr. George Martin. I'm a practicing medical dermatologist here on the island of Maui, and I moved here in 1989. But my entry into dermatology was back in 1985 when I was a first-year derm resident at UCLA, and having just finished an internal medicine residency, I began to learn quite a bit about the patients who suffered from vitiligo. And the evolution over the last 40 plus years has been nothing but astounding for these patients who were really an orphan disease for decades. And so my initial experience with vitiligo, we understood it was an autoimmune disease with the destruction of melanocytes. And our first step was to turn off the inflammation, which we did with systemic steroids, topical steroids. We would use methotrexate, and we would attempt to halt the progression. And then over time, TCIs came available, the topical calcineurin inhibitors like tacrolimus, and we began substituting them in for vitiligo of limited areas. Obviously, systemically, if we gave steroids, we cover a broad area, but if it was smaller areas, we could cover them with topical steroids and then to the TCIs. And so fast forward, the entire field has changed with the advent of JAK inhibitors, which really target the inflammatory pathway in vitiligo. And that is to say that the JAK inhibitors target interferon gamma, which is the major cytokine that drives vitiligo and the destruction of melanocytes. And so, fast forward, we have the development of topical ruxolitinib, which was a total game changer and proof that the JAK-STAT pathway was a major pathway involved in the pathogenesis of vitiligo. And drugs like topical ruxolitinib and even systemic ruxolitinib used off-label were effective at turning off the inflammatory process in vitiligo and allowing melanocytes to repigment and the area. And so treating vitiligo, you have to tell your patients and set expectation that areas that are completely devoid of any pigment, any follicular pigmentation, are going to take quite a bit of while for not only just for the inflammation to turn off, which happens pretty quickly, but for melanocytes to migrate in and fill up the depigmented area. If the patient is fortunate enough to have little islands or reservoirs of melanocytes that can migrate out, the hope is that the repigmentation will take place more rapidly. So that's setting expectation.